It is a great honor to have you with us, ma'am, today. You need no introduction because you're a sculpture of humanity. An MMC alumni who did her DCH, MD, and PhD in MMC, trained in developmental pediatrics in Trivandrum, and the present director of ICH MMC. We welcome you, ma'am, Dr. Ramachandra Mohan.
Good morning to all of you. First, would like to start off by thanking Srini, the registrar. I really do not know how many years he's doing this ICT, but I've had the rare honor of kick-starting it every year. I've been the first speaker in all these years, and I thank him for that. And he's definitely a one-man army. He has been doing this for, Srini, how many years now? This is the 9th year. I think he deserves a big round of applause. And one of the most PG-friendly registrars you can never have. One more batch is going to have the luck of having him around. Anyway, let's get on to the topic. Most of my slides are going to be repeated for some of you who have been probably volunteers last year, because there's nothing new in development. I mean, I can't say there's any update as such. So let's quickly go through these slides. It's just going to be a refreshment for those of you who have worked in a development clinic. And for the others, probably it'll just jog your memory if you've heard something earlier. So if you look at the global statistics about people with disabilities, what percentage do you think have disabilities? About 10% of the population would have disabilities, and out of which 80% of them live in developing countries. 15% of them are severely disabled, they need assisted devices or family support. And children with disabilities are much less likely to attend school, and therefore their employment chances are less, and they do not contribute very usefully to the society. For all these reasons, we have to pick up disability as early as possible so that we reduce their intensity and make them productive individuals. So we know that disabilities can be due to causes which are present at birth, some of which we are not able to find out even with the best of scans, and acquired. So that can be a result of chronic illnesses, injuries, mental health problems, birth defects, malnutrition, and communicable diseases. So if you take disabilities as such, they are divided into several categories. Physical disabilities in the form of a traumatic brain injury, spinal cord injury, cerebral palsy, epilepsy, neural tube defects, etc. Cognitive in the form of intellectual impairment, emotional behavioral disorders in the form of depression, phobias. Let me tell you that even childhood depression is on the rise now. Conduct disorders, ADHD, etc. Sensory disabilities in the form of visual and hearing impairment. Autism has become an epidemic now, and we are seeing a whole lot of children in our OP on a regular basis. Specific learning disabilities with reading, writing, and math, and chronic health conditions which can cause long-term problems. So the causes of disabilities, if you see, we can divide them into prenatal, perinatal, and childhood causes. I'm not going into the details of this, but why do we need to know the etiology of any developmental disorder? We want to know if it can recur in the family. We would like to know whether it can be prevented, whether there is any therapy for it, and if there is a management, how do we go about doing it in a way which would suit the family. And we would like to prognosticate. Some of them may be life-threatening conditions, like in the case of metabolic disorders, so the child has to learn to live with certain chronic disorders, so we'll need to prognosticate. Unless we do that, we cannot involve the family. And then you know that up to a point we can continue the testing. After that we have to stop because other investigations are not available. So these will be the 4 elements of evaluation. We start with a history. Most important part of a developmental delay is in the history. Then a physical examination, which will also include neurological and developmental investigation, relevant lab investigations, referrals, consultations, all those will form the part of evaluation. So we know that they are chronic heterogeneous disorders, okay, which have a delay in one or more of the developmental domains in the form of gross motor, fine motor, cognitive, social, and activities of daily living. So when do we call it global developmental delay? When there is more than one domain involved. Total number of global developmental delays in developmental delay will be about 1 to 3%. So how do we arrive at the etiology? It's very important, as I told you, to get the history. So first is maternal history. So maternal history, as you know about the age, socioeconomic status and things like that, but in particular we'll have to ask about the history of gestational diabetes, PIH, bad obstetric history, intracurrent infections and chronic medical conditions. When it comes to intrapartum history, we'll have to know whether it is a preterm or a term labor, whether it's spontaneous or induced, what is the duration, mode of presentation and the means of delivery. This is the most important history, if you say, and most of the time we do not get adequate data on this because it is coming from some other institution. So labor and delivery, difficulties during the labor, meconium stain like fetal heart abnormalities. Why a cesarean section? Just not enough if we ask for a cesarean section. If it is an emergency, we'll have to know why the cesarean section was done. Of course, birth weight, ABCA scores. More than all this, the stay in the NICU, that's very, very important. So that will tell us whether this child had a transient condition or a condition which is going to have implications in the neurodevelopmental outcome. So this is the risk stratification that we are using in the follow-up clinic. I don't know if any of you have seen this earlier. So this is a tool which has been developed by Trivandrum CDC, and this is very useful. Okay, so we are having a booklet which is used for follow-up in our CDC in ICH, and this has the risk stratification. I'll tell you how this helps us. It helps us because you would know whether this child is having a mild risk or a moderate risk or a severe risk for delay, and it is also going to tell us where the patient should go subsequently for follow-up. So in case this child is coming under the severe category, this child necessarily has to come back to your unit for follow-up. Whereas if it is a moderate risk, they can probably be seen by a local pediatrician. If it is a mild risk, the primary physician can manage these conditions. And it also helps us when you're counseling the patient. You can tell them that since your child has this and this risk factor, this child is most likely to have some problems which require follow-up. So I don't have to tell you the importance of family history in a developmental delay. So socioeconomic status matters very much because there are certain conditions which can be missed when the parents are more occupied with their own jobs and their income rather than concentrating on the child, and certain diseases will come in those conditions also. Find out about the siblings, find out how well developed. It is very important that you mention whether what that other child is doing, the elder sibling or the younger sibling attending school or having any other problems. And a neurological disorder. So we know that epilepsy, convulsive disorders, intellectual impairment, IEM, all that run in families. Consanguinity and bad obstetric history, as I told you earlier. Developmental history. In developmental history, it's at least for exam point of view, you need to mug up the milestones. At least the major milestones you should remember. I'm not going to go through that because it is all available in all the textbooks. So gross motor, fine motor, social, language. And if a child is a little older, beyond 3 years, activities of daily living, about feeding, dressing up, combing the hair, things like that, we'll have to ask. So when all that is ready, we are ready to do a developmental assessment for the child. This is done only by a developmental pediatrician who is trained in this. So you need to have a friendly environment, all playthings and all that should be there. So if it's a small child, the lap of a caregiver is enough. Otherwise, you need to have a table and a chair. So physical examination, you have to strip the child and examine the child thoroughly. Only then you will look at the back, you look at the gluteal region. So there are certain like spinal defects and all that which you can miss. So head to foot examination, look for even a minor dysmorphic abnormality, the dysmorphic feature. Weight, length and head circumference. So we have to necessarily plot it in the WHO growth charts. If it is a preterm child, we can use Fenton growth chart till the child is about 50 weeks old. Head circumference, we all know the rate at which it increases. It is mandatory that it is plotted. Any abnormal increase or decrease in the head circumference out of the percentile chart of that particular child is something to be noted and to be immediately attended to. Okay, I'm not going into the details of this. You know all the syndromes associated with these conditions. In addition to that, is that enough if you just do a outer scanning? No, we need to check whether the child has. So there are certain conditions which can cause a delay, like a congenital heart disease, or the child has had a surgery. Those things will prevent the child from acquiring milestones at the appropriate time. Don't forget to look at the genitalia. Very often we may miss an ambiguous genitalia if we have not specifically looked for it. Okay, so we know neuroectodermal, therefore skin, hair, nails, these have to be specifically attended to. Extremities, before a child leaves the neonatal unit, don't forget to look at the hips. That can be the cause of delayed crawling or walking. So neurological examination. So in the newborn period, we do something called a Hammersmith neonatal neurological examination. There are two forms. One is a short form, the other one is the elaborate one. In the short form that we administer, if you see the central gray area, if the child belongs to the central gray area, this child is normal. Okay, why do we have to do a neurological examination in the neonatal period? Because there is an 85 to 90% chance of us picking up a delay if this is abnormal. So there are 12 to 14 items on a one-page proforma, and 2 or more abnormal findings are warning signs. So if you find 2 or more abnormal findings in this, then you do a complete neonatal neurological Hammersmith examination. So there is a 98.5% chance of us picking up abnormalities. So this is the complete neonatal Hammersmith neonatal examination, and I'm not going into the details of this, but here again, if the central columns of the child is in the central 3 columns, then this child is normal. The 2 extremes say that this child has an abnormal neurological finding. So what happens beyond the neonatal period? We have something called the Hammersmith Infant Neurological Examination, or the HINE. This is what is practiced universally now. It is a structured, objective neurological examination. So here we have a score. So if you see, there's a score of 3 maximum and a score of 0. Okay. So this is how it is. So if the child is normal, you give a score of 3. If the child is abnormal, you give a score of 0. At the end of this neurological examination, depending upon the age of the child, we have specific scores. If the child's score is less than 57 at 3 months, this child has a 90% and above chance of of becoming a child with cerebral palsy. That predictive these charts are, and they are being extensively used now. So I have not got it down, but the scores are 57, 60, 62 and 65 at 3, 6, 9 and 12 months. So at 3, 6, 9 and 12 months, scores of less than 57, 60, 62 and 65 says that this child is a potential child with cerebral palsy. So now we have done the complete examination of the child. Now we go on to the investigations. So why do we do investigations? As I told you earlier, we need to know why this child has developed this problem. Again, the recurrence risk, prognostication and management. So when do we suspect a metabolic disorder? When there is a family history of consanguinity, when the child has acquired milestones and then has started dropping them with regression, when the child has features of becoming better, when it is waxing and waning symptoms, when you have suggestive dysmorphology, when you have non-ectodermal, so other than the skin and the hair and nervous system, other organs like liver and all that involved, you can think of it, and if there is white matter involvement. But screening will only pick up in about less than 14% of cases. So in case you're not able to pick up with all these tests that you have done, then think of iron deficiency anemia or lead poisoning. In addition, do a complete hearing examination, vision examination. Don't forget the humble thyroid, which can be the cause for all these problems, metabolic screening or neuroimaging. So then further down, you've done everything, still you haven't got an answer, then you have to go in for cytogenetics, EEG and all the other neuromuscular tests that you would do. So when can you say that this child has got a potential problem? When there is a persistent lack of alertness, a child who refuses to make eye contact, decreased spontaneous movement, or the child is persistently hyper-excitable and very hyper-alert to noise, when there is a constant fisting, asymmetry of posture, child has a delayed acquisition of milestones, excessive head lag, delayed social smile, tonal abnormalities, ocular abnormalities, not responding to sound, persisting primitive reflexes, deep tenon reflexes, and slow head growth. So this is one of the common questions that they would ask you: what are the early signs of cerebral palsy or any other neurological disorder? So now we quickly move to the second part of our talk, which is about screening. How are we going to? So this is about how do we pick up developmental delay, early detection, and this is about how we pick up a developmental delay in an apparent normal population. So that requires an early screening, which will lead on to an early action identification and management, which will therefore result in better outcomes, especially in school performance. So this is the sequence. So surveillance is where it is like a CCTV. Everybody goes through the CCTV, isn't it? And when do we pick up? When we have some suspicion, we pick up the person and do a frisking. So the frisking is the screening that we do. So screening is a structured tool which is applied to the child who you thought was apparently normal, but it cannot confirm the diagnosis. If you want to confirm the diagnosis, you have to go ahead and do a full-term developmental assessment. So the first two things can be done by a pediatrician. Developmental assessment has to be done by somebody trained in development. So I'm not sure whether the backbenchers can see this, but this American Academy of Pediatrics says that we will have to do surveillance of all children, and if there is a risk of these children, then you administer a screening tool. If the screening tool is positive, then you send this child for developmental assessment. Okay, and if this surveillance does not, so what will happen if this child looks apparently normal? Shall I just send the child off? No child should be out of your radar. They have to come back at 9 months, 18 months and 30 months according to American Academy of Pediatrics. So what do we do in our clinic? All children come back after the neonatal stay. They come back at we follow 4 months, 8 months, 12 months, 18 months and 24 months. So 5 visits within the first 2 years. Okay, 4, 8, 12, 18 and 24. So if you're not able to go that far, I don't have the time, how do I follow up these children? You can use charts like this in your clinic. So just display this. If you have it in the local language, it's even better. So a parent who comes sitting in the lobby and waiting for time to see you, we have a simple chart in Tamil outside our CDC, and even if patients who are going to some other OP, they will look at that. Just 4 milestones are given in that. And they have come self-referred. They say that, okay, my child is supposed to be like this, but it's not like that. So we have to create awareness. Okay. So for that, we can use one of these patient-friendly charts. So if you're going to do screening, there are 2 types of screening tools. One is parent-based. The other one is when you directly administer. So directly administered tools, this is the simplest of those tools. It's called a development observation card. Just 4 milestones. Social smile, head control, sitting and standing at 2, 4, 8 and 12. So this can be made like a seal and put in your discharge summary or even displayed in your clinic. Make sure that the child can see, hear and listen. So the other one is grading. So each milestone goes through 5 stages. So if a child is coming at 4 months, it is not necessary that this child should be at this. This is complete head control. It's okay if the child is even at this. 3, 4 and 5 are normal. So just to tell you, this is also a screening tool. If you find that at 4 months, the child is at this stage, then the child is delayed. Same thing for sitting. Sorry, half the pictures are missing. Okay, so sitting is with support. He's sitting, this is with the back support. Here somebody is supporting him. He's sitting with the back straight. Here he can turn. Here he is getting up from the lying position. So here again, anything above 3 is normal. Standing again, anything above 3 is normal. So how do we interpret? As I told you, 0, 1 and 2 are abnormal for that age. So this is the Trivandrum Development Screening Chart. It was first brought out in 1992, and this is the latest one which has come in 2013. Okay, so this is very simple. You just have to draw a line against this child's age line, and all milestones completely to the left of the age line the child should have achieved. Supposing this child is 12 months, only this, we don't take this item because it is crossing the age. Okay, so only these 3 items you have to administer. If this child has achieved all those 3 items, this child is normal. Okay, it takes barely 3 to 5 minutes. This again for older children. The same way we have the Trivandrum, we have the language evaluation scale, same thing, same, because we know that delayed language is one of the major problems we are seeing in children these days. So it's important that we have an exclusive language thing also. Then we have a 10 question screen, which is a very simple tool which is being used very widely in the community, especially in countries like Bangladesh it is used. So with these 10 questions, so whether this child has any delay, whether the child can see, whether he can hear, whether he can walk normally, whether he understands what you're saying, whether he gets convulsions, whether he learns to do things, whether he can speak, and whether his speech is different from the others, and whether you think the child is backward. So these 10 questions cover all the childhood neurological problems. So they have found that this has about 80 to 85% sensitivity in picking up developmental delays. So this is what I am following in the clinic, which is the Denver, which is a screening chart, and this one requires some training. So as usual, make the child sit comfortably, keep all the toys in front of the child. So this is how each item is in 2 parts. One is a white part and one is a green part. So white part up to this line is the age at which 75% of the children will acquire the milestone. 1 minute, let me see. Yeah. Okay, so up to this 75%, this grey part is the age at which 75 to 90% of the children would achieve the milestone. So you are drawing the age line. If this child does not attain this milestone, the age line is going through the grey area. This child has not achieved the milestone. I told you that 75 to 90% of the children would achieve the milestone in this age, but our child has not achieved. So we mark it as C, which means caution. Why am I not saying it is delayed? Because it's only up to 90%. If the line is going through, if the line is like this, it is beyond the item, but this child has not achieved it, then this comes as fail. Okay, if the line is passing through, what about if the line is passing through the white area and this child has not achieved? I am not worried, because only 75% of the children will achieve in that, so I am not worried. So white area, I am not worried. Grey area, child has not achieved, I'll write caution. Beyond the item the child has not achieved, I'll write delay. So is the child permitted to have any number of cautions? No. If you have more than 2 cautions in this, that again means the child is delayed. So normal means no delay, up to 1 caution is allowed. If you have 2 or more cautions, or if you have age line is beyond the item, then this child is delayed. Now these are all the directly administered screening tools. So now there is no time for the doctor to wait and administer. That's the reason why most of the pediatricians do not do screening tools, because they don't have the time. They'll be busy treating fevers and things like that. Nobody has time to administer. So now we give the onus to the parent. When the parent is waiting in the lobby, you give them the questions. The parent will mark and then come to you. But you think that they have either given an extra score, or you think the child is not normal, you have to again administer the tool. But some parents who are genuinely concerned will give you the proper scoring. You know, okay, the score is below this particular level, this child is abnormal. So we have 2 parent administered tools. One is ages and stages questionnaire, which is very popular. Only thing is, it has to be available in the local language, and the father should have studied only up to 5th standard at least for him to be able to do it. The other one is parent evaluation of development status. This is just like a 10 questions screen. So this is the ages and stages questionnaire. So here, like, does your child catch a large ball with both hands? If they say yes, they will get 10 points. If they say sometimes, they'll get 5 points. If they say no, they'll get no points. So at the end of it, you will mark it like this. If the child has got a good score, his score will come in the dark area. If it is little less, in the gray area. White area means this, did I say wrong? Sorry. Maximum score is in the white area. Lesser scores will come in this area, like 5, 10 and all that. If it comes in the black area, this child definitely requires a developmental assessment. This I am not going into this. This is just like our 10 question item. Now for autism, we have specific screening charts. One is the MCHAT, modified checklist for autism in toddlers, and our own tool is incline screening tool. So these are the questions. And normally the parent is supposed to say yes, yes, yes. And if they say no for a particular question, that means it is an at-risk response. Only for 2, 5 and 12, it is the other way around. So 2 is, have you ever wondered if your child is deaf? Does your child make unusual finger movements? And the 12 is, does your child, does your child get unduly upset by noise? So if the score is 0 to 2, no problem, you can tell them to come back at a later date. If the score is 3 to 7, then there is a moderate risk and they have to come for follow-up regularly. And if it is 8 to 20, this child has got a very high risk of having autism and needs to be referred to a child psychiatrist. So when the child's results are normal, just tell them to come for a preventive visit some other time later. And yeah. So any child failing any of these screening tests should have a developmental assessment, which is done using either DASI, which is a developmental assessment scale for Indian infants, or Bailey or Griffith. And what are the numbers that you should remember? Anything above 85, if a child gets a score of 85 and above, it is not percentage because it is just like IQ, it can even be above 120 and all that. So above 85, the child is normal. 70 to 85 means there is a mild delay, this child should be under surveillance. Less than 70 means there is a delay. So an evaluation as just the take-home points is the child should be screened at regular intervals. Assessment should be done by development pediatrician or a neurologist. You try to find out what the disorder is. You try to do relevant investigations, because some of these investigations are very expensive, so don't tell them to just do the whole lot of it. Start on specific treatment if available. Try to find out the etiology so that you can prognosticate for this child or for the next. And medical evaluation, if you find that there is a problem, it has to be attended to immediately. And so as a pediatrician, if you have missed the diagnosis in a particular child, you can be in for legal problems. So try to listen to the mother's problems. Even if you feel that the child is normal, if a mother has concerns, that is a reason for which you should send a child for an assessment. So that's the end of my talk. Thank you.